Hi, everyone. First, I want to say thank you so much, Dr. Talebian, for coming on. And if you could introduce yourself and tell us how you got into this and exactly what you do.
Perfect. So I am Sheeva Talebian. I'm a reproductive endocrinologist and fertility specialist at CCRM in New York. I'm OBGYN trained, did a fellowship in fertility, and I've worked pretty much in New York since my fellowship ended in 2008. I have some experience early on in the GC surrogacy realm. I worked in practice in Jersey because surrogacy was not legal in New York. Obviously, now I'm in New York, surrogacy is legal here. So I do have a background in third party reproduction, but obviously I've been practicing fertility medicine since 2008 and do it all.
Okay, very cool. Let's get into the questions. With a diagnosis of unexplained infertility, how do I know when to switch to a donor or surrogacy? What are the odds of being successful with a surrogate when four euploid frozen embryo transfers have failed for me?
Okay, this is an excellent question. And a couple more questions that I would ask this. Unexplained infertility, right? 20 to 30% of individuals and couples, all their testing checks out, but obviously, clearly, there's something going on. It's just our testing's not able to detect it. So when I have patients who are fail, and a lot of times, right, they either go straight to IVF or they may try ovulation induction and IUI a few times, and if not pregnant, go straight to IVF. If those patients are making euploid embryos and are not getting pregnant with euploid embryos, that warrants further investigation. To me, that is a big red flag that there's an underlying condition like endometriosis in the background. So, if I have a patient who has unexplained infertility and I haven't even explored endo as being there, or their symptoms weren't really consistent with endo, but if they do fail one or two euploid transfers, I will do some investigation for more silent endo. So I do typically do a Receptiva uterine biopsy. And if that BCL6 is elevated, it's a special biopsy that's done a week after you ovulate. It looks at a biomarker called BCL6. If that is very elevated, that may suggest endometriosis. So if someone fails one or two euploid transfers, I do offer that test. And if that is elevated, then I want to treat that either surgically or medical management and then the transfers. Anecdotally, and looking at my data, many of my patients go to surgery and 80% are pregnant that transfer afterwards or the second transfer. If they are still failing the transfers and we've addressed endo, whether they do a laparoscopy and it's not there at all, and they're still failing transfers, then I would suggest surrogacy. And you should have at least a 70% chance of a live birth with one to two transfers with surrogacy. But I would say you want to make sure you've ruled out other conditions before you go that route.
I have a follow-up question to that. How do you decide whether to guide someone to go for a laparoscopy or to do suppression like Lupron?
Right. I would say if they have any other symptoms like pelvic pain, IBS symptoms, a lot of bladder, bowel symptoms, I say go to surgery. I find it definitive. So we actually have an answer. We know it's there.
Mhm.
And I refer to a handful of surgeons that I know are very skilled at the surgery, just seeing it, diagnosing it, treating it, and safely treating it. So I would say, to be honest, many of my patients opt the surgical route because they also want that answer. They want to know, is that really what's been going on? Versus if they are very apprehensive to do surgery, then they do the medical route. The Depo Lupron, the 2 months of Depo Lupron, if they have any mood instability, depression, it can be really bad. So I want to be careful with that also in patients who have that history. I'm reluctant to do the Depo Lupron. There's other protocols like birth control pills overlap with Letrozole for 1 to 2 months prior. That seems to have less side effects in terms of mood instability, and that can work as well. But for many of these patients, if you're really under the age of 37 and you've been trying for a long time, tubes are open, you have good reserve, you're ovulating every month, sperm's decent, and negative pregnancy test, and you do a round of IVF, and you actually, with one IVF, make a high number of euploids, that to me is very suspicious for endometriosis. And if you're then failing transfers, I definitely offer that Receptiva, and I would say most are positive. And I've never had a patient go to surgery where the surgeon said, I've had actually one patient go to surgery and the surgeon said there was absolutely no endometriosis, but she had two prior C-sections and she had a big defect in those C-section incision sites where it was actually very thin. And so I think a lot of that inflammation was actually coming from the pelvic cavity through the C-section incision. So the surgeon repaired that defect and then she got pregnant after failing multiple transfers.
I think people want to prolong doing the surgery because it's one more step, but I feel like for a lot of people, I've seen also just helps.
I think again, it is important who you go to. And I think if you go
Right.
to a good surgeon, a lot of times, all patients have said to me, I actually felt better afterwards. I didn't realize I was having all
Mhm,
these
mhm.
symptoms.
Yeah, that makes sense. Okay, next question. Thoughts on using Adderall or cabergoline for excess inflammation in preparation for an embryo transfer? Is endometriosis a cause of repeated pregnancy loss? What are your thoughts on add-ons like prednisone or Claritin?
Yeah, exactly. So again, the definition of endometriosis, I think, is really evolving as we're learning a lot more about it. I think the classic disease in our minds as terrible pelvic pain, scar tissue all over, and infertility as a result of all that scar tissue. Yes, that is one form of endometriosis. But I do think that it's a very enigmatic disease where a lot of times what you see visually is out of proportion with the symptoms. And even mild endometriosis. We're believing can almost trigger like an immune reaction. And so, again, it's very hard and difficult to actually prove, but I do see that patients who are having chemical pregnancies, failing euploids, or we're putting the euploids in and then it's a chemical or it makes it maybe to a sac and then not further. If they do go treat the endo, I have seen them go on to full term pregnancies. Again, if I know a patient has endo, when I do their frozen embryo transfer, I do add some adjuncts to it. So always a baby aspirin. And I do also like what we call the antihistamine protocol, which is slightly longer course of a steroid, a Claritin and Pepsid for a couple weeks, and then we stop it at like the 6 week mark. In my patients, I've not used Adderall or cabergoline to lower inflammation due to potentially endometriosis or other inflammatory autoimmune type conditions.
Okay. Next question. When is it time to move on to donor eggs? How do I determine whether to go with a clinic or a donor egg bank? And how do I choose between frozen or fresh eggs?
Right. So I always say the decision to go to donor egg, it's not one made overnight, right? It's obviously usually a journey, a process. You've tried on your own, you've tried it a couple rounds of IVF on your own. Yeah, there are some situations where your only option really is to go to donor. For example, if you're no longer ovulating, you just no more eggs left, right? Then we obviously, in that case, we can give you stim meds, but you're not going to ovulate. You kind of have to go straight to donor at that point. But it's a decision that takes some time, and you probably can speak to this as well. I've never had a patient come back to me and say they regretted doing it. If anything, they say, I wish I had done it sooner,
Yeah.
right? But there's egg banks and then there's fresh routes. And so where I work, we offer both. We don't have our own internal pool. So we work with a couple different commercial egg banks, or we have agencies that help recruit the donors. And the fundamental difference is at the egg bank, the donors are all screened by all the same criteria: ASRM, FDA, Department of Health. Like they're screened the same way. It's just at the egg bank, the donor goes to that center, she does the stimulation, the eggs are retrieved, and then they're immediately frozen. And you purchase lots of 6 to 8 eggs at once. So they're frozen first. They then get transported to whatever center or clinic you're currently working with, and they get thawed and fertilized there. And so if you're purchasing just one lot, that's 6 eggs. It has to survive the thaw, then fertilize, then grow to blast. I still recommend PGT testing. I know that's controversial, but regardless, you still want to go to blast. And so 6 eggs, when you thaw, you may only get one or two good viable embryos from that. So I think that the egg bank route, what are the advantages? It's faster if you find a good match and it's less expensive, but you're also going to get less. If your goal is really one live birth, I think that could be a good route. The fresh route or agency route, or some clinics kind of recruit their own donors, that's where the donor undergoes the simulation and essentially all of the eggs go directly to you. Some centers, I think, split recipients. We don't, but they're fresh collections. Let's say she gets 18 mature eggs. all are fertilized for use. So you're going to clearly get a lot more embryos to work with in the end with that. So your cumulative pregnancy rate, that route is going to be higher, right? So if your goal really is a couple pregnancies from that same donor, that's probably the better route to go. If you have a chromosomally healthy embryo that came from once a frozen egg versus a fresh, their implantation rate should be comparable, but you're going to just get fewer when you freeze it for a thaw and then go to blast.
And also, I'm posting in the chat a blog post I wrote about how to choose an egg donor and also fresh versus frozen.
Right.
You can read
Right.
about that as well.
Right. And we, as the fertility doctors, always refer to the you to help. How should I think about this? What should I be thinking about? What parameters are important? All of that. And what is the literature? There's a lot of literature already looking at this.
Yes. Yeah, exactly. And I appreciate that.
Mhm.
Okay, next question that we have is I'm 42 and my AMH is 0.67. Should I do another egg freezing cycle? I did 4 so far and only got 3 eggs each time. I have 13 eggs in total from ages 36 through 39, and the meds were very irritating on my stomach.
Again, this is all, I think the question here that I would ask is, what's your goal? If you said, I would never consider a single parenthood, or that's just not for me, I don't see that in the cards, then I hate to say it, the more eggs you freeze, the better the options on the other side, right? But if you would say, okay, I'm 42, at some point I want to be a mom, and whether I use a donor or I don't, or a partner, but at some point I want to be a mom, and maybe I would consider with a donor, and I might consider that soon. You might want to do a round where you actually don't freeze the eggs, you fertilize, and you make an embryo. Whenever we make embryos at CCRM New York, we always chromosomally screen them, so we always freeze them, right? So I would say if you would ever consider at some point single parenthood using donor sperm, maybe you want to do a round and go straight through. Because every time you freeze the egg and then thaw it, unfortunately, you always lose some in the freeze thaw process. And the blast progression rates are a little bit lower in eggs that were once frozen versus going straight through. And so egg freezing as we advance in our age does become less successful for that reason. The number of eggs we retrieve every time goes down, unfortunately, and the chromosomal health of that egg does decline. So you just have to kind of bear that in mind that we can't test that egg alone. And your AMH is not a predictor of the health of that egg. Your AMH is not a predictor of your ability of those eggs to fertilize and result in a healthy embryo. Your AMH is purely a quantity marker. The best prognostic indicator of the health of that egg is your age. And unfortunately, no matter what type of life we've lived, 100% organic, not organic, we exercise, we never smoked, we never drank, still for that average 42-year-old that our egg, the chromosomal health does decline. And the only way to really know what those eggs could do would be to put sperm in them.
Do you think down the line there's going to be ability to freeze eggs better or
We're
test them or?
We're at 90% survival rates. When embryos are obviously at 99 at top centers, the issue really is the way the chromosomes line up in an egg. We've tried to biopsy to test the egg by itself, and you can't. So far, we've been trying the same way we've developed PGT technology for embryos. We've tried for years to really understand the chromosomal competence of an egg by itself. And we've yet to be able to do that, right? We're advancing in what we can do on our an embryo stage, yet we've been pretty stagnant at eggs and sperm individually.
Yeah. Okay, next question. Are there any unique medical concerns when considering a gestational carrier in her 40s using very young eggs or embryos?
So if I understand the question, are there concerns about using a carrier who's in her 40s?
Yeah, that's
Right. Yeah.
the eggs and embryos. I'm not sure if it's this person that is in here. It could have been ones that were frozen many years ago because of cancer. So before some of the PGT was around.
Gotcha. Okay, so the carrier herself, right, was GC over the age of 40. The main concern that we have is just higher rates of preeclampsia, gestational diabetes, like all pregnancy complications do increase technically after the age of 35 and then incrementally. But we definitely still use GCs that are in their 40s. Most are known cases, like a lot of centers do for commercial GCs or for paying for a GC. We do tend to have age cutoffs that are like 40, 41, 42. But we can most certainly consider a known GC who's older. Obviously, we would have to get her medical history, make sure she doesn't have any underlying medical conditions, have her undergo clearance with a high risk OB.
Next question is, what is your criteria when deciding to keep a frozen embryo transfer protocol the same versus adjusting it? I've had one fail, one missed miscarriage at 6 weeks. I have 3 pgt-a embryos.
Protocols for FET protocols. So historically, most centers always did what we called programmed or controlled, which was basically you're not ovulating naturally and we're completely controlling the process. So sometimes we did birth control pill and Lupron suppression leading in. Sometimes it's just day 2 they come in. And the concept is if you start high dose estrogen early on in your cycle, that's going to tell your brain don't ovulate. So we're controlling it. It's all mapped out. So high dose estrogen, get that lining nice and thick. And after 12 days of estrogen, when that lining looks nice and thick, start the progesterone on top of the estrogen. And typically we always do the transfer on the 6th day of progesterone exposure. So that's what we call a controlled or medicated FET prep. And that is historically what a lot of centers did. It was kind of what we knew how to do. And it also allowed for a high degree of control because you know exactly what day the transfer is going to be. It doesn't have to be on a specific day. So you could avoid weekends. You can make sure you're going to do it during the week when your specific doctor is going to be at the clinic. I would say I've really moved away from programmed or controlled as we've learned more about protocols and as IVF went less far and far like fewer fresh transfers and mostly frozen transfers, a lot of us started to explore what about natural cycles? What about modified natural cycles? So the other protocol that one can choose is a purely natural, like track the woman's natural ovulation and sync it to her natural, exactly like her LH surge. What I like to do a lot is what I call a modified natural FET, which is where they come into A3. If they're baseline, we do letrozole for 5 days. Then around day 9 or 10, we start monitoring the follicle, estrogen levels, lining thickness. Once we see that estrogen spike, I usually do a trigger shot. And then 6 days later is the transfer. I still give luteal support after trigger with an estrogen patch and progesterone suppositories. So you're naturally ovulating, so your ovaries are making natural hormone. So you want to make sure you're not having any unprotected intercourse because sperm can hang out. You can have a second pregnancy, but that's a natural. So what's the benefit to that? It's less synthetic hormone. Most patients don't have to do the progesterone oil shot. The body's making that natural hormone. And we don't have enough data to say it definitively, but there's some thinking that if that lining is made with that natural estrogen versus synthetic, maybe it's going to be more receptive. But really, to go that route, the woman does need to have more or less a good natural cycle. If the woman has very, very short cycles, like 21 to 22 day cycles, meaning she's ovulating on her own very quickly, that's not ideal, right? That's too short of what we call a follicular phase. If she has really, really stubborn PCOS, and even with letrozole may not ovulate in a timely manner, that's also not a good route for them. And then obviously, if they're kind of at the point where they're perimenopausal or menopausal, that's not a good route either. So I really tailor my decision as to which FET protocol to use based on the patient in front of me. What is her history? If she's been pregnant before naturally and she still has good cycles, I prefer a more natural protocol. Even if it was a miscarriage, I know that her uterus implanted in that natural setting. I tailor it to my specific patient and what their history is.
Why letrozole if they're doing natural?
So a lot of times patients may want to do the cycle right after they did an egg retrieval.
Mm,
And whenever you do your egg retrieval and you get your period that next month, like you retrieve today, your period's in 10
yeah.
days, your next cycle is always really delayed. And patients call all the time freaking out. I don't understand. I'm day 20. I haven't had a surge yet.
Mm,
Your next
mhm,
cycle after an IVF, you're
mhm.
always delayed because you get your period almost a little earlier than you normally would, like your luteal
Right.
phase, like, right? You get your period earlier, and then it takes your pituitary a little longer to get that follicle to grow. So I tell every single patient, whenever I retrieve them, I say, if it's someone who's not going on birth control pills right after, I'm like, your next cycle, it's going to be 30, 35 days. Don't panic. So that's one of the reasons I like the letrozole. A lot of times they're doing it after rounds of fertility treatment where they're no longer a 28-day cycle and they might be a 20-day or a 22 because
Right.
their bodies are just thrown off. Or sometimes they do a retrieval. I put them on a pill right with the period after the retrieval, waiting for like PGT results. And if we're happy with the results, we can stop the pill. And again, that's going to suppress them too. So the letrozole just kind of helps them ovulate
Okay.
more timely. And then there's some theories that maybe it helps the lining receptivity, but I do it more just so I know, like, we're not going to be waiting like forever to
Right.
ovulate.
Okay, that makes sense. Next question. Does PGT-A significantly reduce the risk of miscarriage? Is there any downside to it other than cost?
This is really probably highly debated in my field, and it really depends on who you speak to, which RE you speak to. I of the history and the training where I am a proponent of PGT-A, regardless really of age group. To me, and again, I advocate for the technology that my lab is best at, right? So you can't take my data from my clinic and translate it everywhere, right? It doesn't, that's IVF is really specific. Every center has their data on success rates based on what their clinic, their lab offers. But our highest live birth rate is from a single embryo that's been PGD tested and frozen and then thawed at a subsequent time. That's at CCRM New York. And so to me, the benefits of the PGT testing are you get that data on the chromosomes. And yes, if depending on your age, your miscarriage rate due to chromosomal aberration in the embryo is a minimum of 20% and up to 40%, depending on your age. And so if this is a chromosomally screened embryo and we do the transfer and you have a positive pregnancy test, the chances of it miscarrying drop to almost lower than 15 to 10% because you really ruled out most causes of miscarriage. So it does lower your miscarriage rate due to chromosomal aberrations, if that's why you're miscarrying. The other reason that I find it extremely helpful is I actually have the data on that embryo. In the days when we weren't testing embryos, and I put the embryo in and the patient wasn't pregnant, I don't know. Is it the embryo or is it something in the environment? Is it endometriosis? Is it a blood flow problem? Is it a structural problem? Is there a fibroid that's in the way that we didn't think was it? And right, what else is it? And so when you have that data, I think it helps you move forward. I always say when you put an embryo in, whether it's tested or not tested, and it works, you're not looking backwards. But when it's not working, we need to know how to move forward. That's so to me, that's another reason it's super
Mhm.
helpful.
Does CCRM allow people to transfer embryos from other labs?
So generally the answer is no. We
Mhm.
generally don't take embryos from outside centers. There are some exceptions to that.
Okay. Next question is, how do I navigate a physician pushing for a second ERA after two chemical pregnancies and one ERA or Receptiva that led to 2 months of Lupron? I'm 30 years old and did a modified natural transfers. My doctor didn't change protocol between transfers. Is that normal?
If I'm understanding the question correctly, if you've done an ERA Receptiva once and acted on that, I don't usually repeat it. Is that what the question
I
was
think that's what the
saying?
question is. Yeah, it
Yeah,
sounds like the
like
doctor's asking for not to do another one after
I
the
would,
two chemical
yeah,
pregnancies.
that's not what I would recommend. If you have your euploids, you do your ERA and Receptiva, you do 2 months of Depo, adjust your progesterone if the ERA said to do it, and then you do your transfer and you still have a chemical. uh, I'm not sure why repeating the Receptiva is gonna, like, why would you repeat it again? Okay,
Mhm.
hold on. She said, yes,
Oh,
she clarified.
doctor wants to do another one to check the window of reciprocity after adjusting the transfer date.
Okay, so the doctor doesn't want to repeat the Receptiva for the BCL6, just the ERA.
Sounds like maybe just the timing. Nope, just the
Nope,
ERA,
just the
yeah.
ERA. Yeah. Again, so there have been two pretty good quality studies that came out looking at ERA not improving the outcome or not changing the outcome. I, for what that's worth, there's actually some literature saying that the ERA is not in a significant way changing the outcomes.
Do you use it for that
I
or no?
I don't, once these studies came out, I really
Stop
kind of
or
stopped offering it. Receptiva, I do find
mhm.
extremely helpful. If someone's going to do a mock month, I'll say it depends. Like sometimes I have patients who we just do the Receptiva. I see no reason to do a mock, but if they fail to transfer from me and we're curious, I'll say, listen, if we're spending the month to do the Receptiva, if you want to add on the ER, it's the same process. Like we're not, it's just go in twice, send one sample to
Right,
Receptiva,
right.
send,
So you might as
one
well.
sample. Yeah. But I'll say to them, listen, like it is an added cost. Like you have to pay for the ERA separately. That's not coming to me, it goes to the ERA company, and just understand literature doesn't really
Support
support
it.
it. Yeah.
Yeah. What are your thoughts on all the immunology stuff? Will you send someone to that?
So again, I will say I used to go that route a lot more, and then I started to dig further for endometriosis and treat the endometriosis, and I don't need that route as much. I think a lot of patients who have these autoimmune, do these huge immune panels and are having abnormal levels, that could be related to endometriosis. And
Mhm.
so to me, treating the endometriosis is
Mhm.
actually easier than treating that, right?
Right,
Because going
right.
that route, then you're doing intralipids and
Right.
IVIG, and versus if you go to a really good surgeon who's safe and you do a laparoscopy and they actually see it and you remove it, like to me, I'd rather really treat the problem than that put band-aids on it.
Right. Right. What are your thoughts on transferring mosaics?
It again, after genetic counseling, if it's all the patient have, if they do the genetics consult and they understand the risks, we'll do it.
Mhm.
But
Okay.
again, I'm not a geneticist, so we refer
Right,
to the
yeah.
actual
To
genetics
the
counselors for that. Yeah.
before I
And
get to some
definitely have
mhm.
live births, like for sure.
Yeah.
I have had plenty of live births over the years from mosaic embryos, healthy pregnancies.
Yeah. Before I get to some of the chat questions, since you are into fitness and I am into fitness, and I also used to, back in the day, be a personal trainer for pregnant women, I'm curious, one, what limits of exercise should they be doing when they are doing IVF protocols? And then two, do you bed rest after a transfer or can you move around?
Definitely move around after transfer. Yeah, so let's talk about exercise, physical activity, right? Like the American College of OBGYN recommends that pregnant women engage in moderate to intense exercise most days of the week. Okay. So now trying to conceive, I think there was this myth that we're just working our bodies too hard and that's why we're not getting pregnant. And again, listen, exercise should be part of your daily routine in a healthy manner, right? I would say calories in, calories out. Yeah, sometimes I have patients, they come through the door, you know them, I know them, they come through the door and you could tell that they're not putting in what they're putting out of their body,
Like
right?
reds,
And
like
yeah,
what, yeah.
yeah, they're just
Um,
it's that athletic
yeah, yeah.
triad. They're
Mhm,
just and then right or disordered eating.
mhm.
That's a yes, there
Different
are
category.
different category. I'm not
Yeah.
talking about that category, right? I'm talking about the average person who should be working out moderately most days of the week, right? So that should continue while you're trying to conceive, right? If you're actively trying to conceive, you shouldn't be aggressively training for an Ironman where you're losing weight and you're stop ovulating, right? That's the telltale sign. Like when athletes start losing their periods, that's a problem. That means too much, right? And so I'm not talking about that, but you should be working out. Now, once you start stims, I tell my patients the first couple days of stims, work out as much as you like. But once your ovaries start to stretch, the reason we tell you to scale it back is that think of your ovaries, your fallopian tubes are on old school telephone cords, the ovaries hang from them, and now you're bouncing around. You don't want them twisting, right? Or you don't want a follicle bursting and bleeding, right? You're most at risk of that once your retrieval happens for the week right after. And so the reason that I tell women to kind of scale it back during their stim is mostly just the safety of their ovaries. We don't want anything twisting. We don't want anything bleeding. Then you need a laparoscopy and then you can't work out for 6 weeks, right? So that's the reason to tone it down there. But there's still walking is fine as much as you want if you feel up for it, arm weights, certain stretches, right? There's different body workouts that you could do that are safe. Transfer protocols, one in prior to putting the embryo in. I'm like, whatever your usual routine is, you should do it. Exercise as much as you want, all of that. Once we do the embryo transfer, I do not recommend bed rest afterward. I tell my patients just have a relaxing couple days. If they're like somebody who really works out every day, I say maybe for 48 hours, just kind of take it easy, just go for some walks and then ease back into light jogs, biking, just kind of, but
And
nothing
what
too
is the reason
crazy.
is that? Because it's not because it's going to fall out, which I
No.
think people say.
There's no reason. There, like you
Okay.
should be able to work out, right?
Okay.
You should be able to work out. The only reason I tell patients maybe don't engage in anything too strenuous is if you have a negative pregnancy test, it's not because you went for a 10
That's a
mile
hundred
run,
percent what I say.
but it's
I
not
say, because
because you
you
went for a
don't
10.
want to blame yourself.
You don't want to blame yourself,
Yeah.
right? It's like you don't want to put the embryo transfer in and then go do some crazy hair color
Yeah.
and highlights and be
Yes.
with like
Yes.
formaldehyde in your hair for hours, right? Like
Anytime someone asks, should I do this after transfer? I say, are you going to think that caused it not to work? And if
right.
they say maybe, then don't do it.
Exactly. Same,
Yeah.
same. It's really just it's that, right? Because if your body is used
Yeah.
to running every day, right? And again, now that everything's frozen embryo transfers, or most places are frozen embryo transfers, it's different. When we used to do fresh IVF transfers, your ovaries were still huge, and so you really
Mhm.
couldn't work out just because you didn't
Right.
want them
Yeah.
twisting. But
Hmm.
now with these with FETs, even natural FETs, you will have a couple. You may have one or two ovulation sites called a corpus luteum, and so you may feel some fullness and bloating. And in those cases, I'll say maybe don't do anything high impact or too much core workouts if you're really feeling that ovary. But it
Hmm.
is not going to cause you to not implant or miscarry, but we also don't want people blaming themselves.
Yeah. Right. What do you think of, while we're talking about weight, what do you think of GLPs for someone who is overweight or?
They really like a 2 month washout before you actually get pregnant.
Okay.
So you could do it leading into your egg retrievals. We usually have you stop like the week you
So
start
you're a
injection.
proponent of like to
It's
help
if it's
someone?
it's indicated, yes.
Mhm.
But again, they have to have a 2 month washout before you do your embryo transfer.
Okay. But it's interesting because I've heard other REIs say 1 month and some say just a couple weeks. I feel like it's all over the place with that. And again, they're new, so.
Yeah, yeah, but there are documented can cause birth defects. So,
Oh,
yeah,
okay. Yeah, always stray on the safe side, right?
right.
Okay, so questions from the chat. Going back to kind of the antihistamines. Is antihistamines and Pepcid only for endo, or do you give it in general before transfers?
I do it if someone has a failed transfer. I'll just add it in. If
Oh,
they're doing a second
okay.
one, I'll add it in. I'm like, okay, we could just add this in case. But if I
Okay.
know they have endo, I do usually add it in as well.
Okay. And by the way, guys, if you have any questions, ask them now in the chat. Okay, next question is what is considered, this was in reference to something you had said too. What's considered high dose estrogen and what's considered a thick lining?
Okay, so for the medicated or programmed FETs, there's all sorts of protocols. Some centers do estrogen patches up to 3 or 4 to get it thick. Some places do oral estrase, 2 milligrams 3 times a day. You do need some degree of estrogen to build that lining. And then in the blood, there's variations. Like the minimum level we like to see is about a 150 in the blood. If their lining isn't thickening up very much, you want to see the estrogen higher just to see if it gets thicker. And then in terms of linings, I like a minimum of 7 millimeters and trilaminar. So really, it's that trilaminar that we like to see, that pattern. That's kind of letting us know that, okay, that's a healthy uterus. There's no scar tissue there. And lining thicknesses can vary from woman to woman, and there's various factors that can affect it. Your actual adipose tissue makes estrogen, and so women that tend to be extremely lean with low body fat don't tend to get the thickest linings. If the lining really is under 6 millimeters, that's not ideal.
Would you do 7 for a gestational carrier? 7 lining?
A gestational carrier should have a thicker lining than
Okay.
7, right? It
Yeah.
should be thicker.
Okay. So here's the one with the case of, I think, the older gestational carriers.
I got it.
This person says, I went into chemotherapy induced menopause at 29 years old. At 49, tried to jumpstart my uterus for transfer with my own embryos made pre-chemo.
Got it.
Endometrium didn't thicken above 6 after long-term estradiol, Premarin plus
Yeah,
progesterone
yeah,
regimens. Any other ideas for post-chemo uterus?
yeah. I would say there's just, yeah, there's like estrogen, valerate. People have tried Viagra, like vaginally to increase blood flow, but that might just be, or you could just try HRT just for try to build it month after month, and maybe eventually that endometrium comes back.
Mm. Does it have to do with also age too, or no?
It has to do with the years of no estrogen exposure, right? I think that's what it is,
Yeah,
right?
got it.
Because if you weren't put on any hormone therapy after, which if it was breast cancer and that's why you had the chemo, then you can't go on HRT, right? So it depends. And unfortunately, a lot of times after cancer, you can't go on hormone therapy.
Right.
And so then that uterus is just basically deprived of estrogen. So I think it just, yeah, I guess she wrote it was lymphoma. Did they give HRT after? Because if they never gave HRT,
Was
I
on the pill
wonder.
continuously for all the
Oh,
years in between.
maybe it was just like a low dose.
On
Huh.
Ocella.
Acela, yeah, yeah. So I'm wondering though if you just keep trying to do like the prep, like after several months, if that lining regenerates a little bit.
Do you typically recommend a natural or modified natural transfer right after a 2-month course of Depo Lupron, or would you recommend a medicated transfer to avoid waiting for the first menstrual period to come naturally?
Yeah. So when you do the Depo Lupron, you're pretty much committed to a programmed or what we call a STIM FET. So you're committed to either going straight into the medicated program, so all synthetic estrogen progesterone, or starting injectables. That's the other way. But the whole point of the suppression, you don't really want to get your body back into the right? That's the whole point.
Right.
Yeah.
What are your thoughts on leaving fibroids or having surgery to remove them? They are not within my uterine lining. My doctor is not concerned with them, but curious if I might have a better chance of staying pregnant if they are removed. One failed FET and one miscarriage from FET.
So the studies all suggest if it's really not in the cavity, it's not over 5 centimeters, it's not distorting the cavity, that it shouldn't be related to the miscarriages. And the studies say don't remove it. But again, fibroids, it's all size, location.
Can you see those on a ultrasound really well?
You are you
The
asking if
fibroids?
it
No,
okay.
I'm asking you.
Oh yeah, 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 oh yeah, yeah.
You
Fibroids are
can?
clearly seen on
Oh, okay.
ultrasound. Yeah, and then you can always order an MRI to really know exactly
Okay.
how many and where they are.
Got it.
But the question
Okay.
is, if you have
Mhm.
fibroids, do you also have endometriosis? Because
Mm,
sometimes they go hand in hand, right? So that's
right.
the
And it could be
thing. Like,
silent or right.
yeah, yeah. Like, why are you not sticking? Why are you not in chemicals? So the only benefit maybe of going into do the fibroids is that they're going to treat other stuff too.
Is endometriosis, do you think, is it happening more because of something in our environment, or do you think that it's always been there and we just didn't know as much about it?
I think both.
Mm. What do you think
I
is in
do
the
think both.
environment that's just pollution, just all the put in our
Yeah,
body, or the
yeah, who knows, right? We like tampons at a very
plastics?
young
Yeah.
age,
Hmm.
plastics, all that aerosols,
Right.
right?
Yeah. Here's another question. I've had a hysteroscopy.
Hysteroscopy.
Would endo have been seen during that surgery?
No. So people always, I think this is very confusing. So endometriosis by definition is in your pelvic or abdominal cavity. So hysteroscopy, you're only looking at the inside of the uterus. You can diagnose endometritis, so you can sample the lining at the time of the hysteroscopy and send that tissue to look under the microscope and do a special stain for something called CD138, and you can diagnose endometritis, which is inflammation of your lining. That is not endometriosis. Endometriosis can only be seen in a laparoscopy.
Okay. I have a couple fun, lighthearted questions for you that I ask everyone. If you had to swap careers for a month and you were already amazing at it, what would you choose?
Oh, if I had to swap
Or if you
careers?
got to and you're already really good at it, so you don't have to train or anything.
Oh, God, I think I What would
Yeah.
it be? Well, I always joke that like I always wanted to be a spin instructor.
I was one. I used to teach cycling for so many years.
I started spinning in med school and I'm like, this looks so fun. I would love to be
I have a
a
soul
spin
cycle
instructor.
bike.
Yeah. Yeah. Like I'd love to be a
No,
spin instructor.
that's
No,
awesome.
I'm joking. But it's like medicine is all I know, right? It's just
Yeah.
all I know. And the more I do it, the more focused you really become.
Yeah, so something
Yeah.
lighthearted. It's only a
Yeah.
month. You get to
Yeah.
just,
Oh, yeah. I'd be a soul cycle instructor
yeah.
for a month in Europe,
What
though, in a different
in Europe?
country.
Yeah. Someone said I'm jealous of your muscular arms.
Oh, gosh. And I'm wearing a shirt.
Okay, second lighthearted question. Do you go to bed with your email inbox at 0, or are you one of those
Oh,
people with
my
thousands of
God.
unread messages in your icon?
Oh my God. My Gmail and my work Outlook, like people are horrified. There's thousands of messages, not from patients. Like my patient emails, I always answer, but
Are you one of those that doesn't unsubscribe to anything? Like you see them in
I
like
don't, I
every
try to unsubscribe and it still keeps coming.
right, your Best Buy, you have the
Everything. I
DoorDash, you're just
can't
like,
take
oh,
it. And I really try to unsubscribe, but then they keep coming back.
that's funny. Okay, well, that's it. Thank you so much for
Oh,
joining us. I really appreciate that
yeah, of
you were
course.
willing to come answer these questions. Yep. So thank you.
Anytime. Happy. And if people have other questions, if you want to email me, I can email them back.
You're amazing.
All right.
Thank you.
Thank you. Have a good